Look at another syndrome here, which is very important. Okay, it's a metabolic syndrome, and this is a syndrome of mineralocorticoid excess. Syndrome of mineralocorticoid excess. Okay, so for mineralocorticoid excess, you know, is also called apparently mineralocorticoid excess. Apparent mineralocorticoid excess. So it's a rare genetic disorder and it's caused by a deficiency in an enzyme which is known as the 11 beta hydroxysteroid dehydrogenase type 2. So it leads to what? There's unregulated activation of what? Mineralocorticoid receptors by cortisols. Okay? So let's discuss it in depth. So let's look at the normal physiology. So normally this 11 beta hydroxysteroid dehydrogenase should convert active cortisol into inactive cortisol, okay, in kidneys and colon that are mineralocorticoid sensitive. So this ensures that aldosterone, not cortisol, will bind to what? Mineralocorticoid receptors. But in apparent or syndrome of mineralocorticoid excess, there's a deficiency of that enzyme. That's 11 beta hydroxysteroid dehydrogenase. So cortisol is active. So cortisol will still bind to those mineralocorticoid receptors. So it will now mimic aldosterone action. So it will lead to what? Sodium retention, potassium excretion. So you are retaining sodium, you are retaining water, you are taking out potassium. There's a lot of hypertension. Then for renin and aldosterone, they are also suppressed due to volume expansion, you know. So this is what we got. Okay. So this enzyme is missing or less. So cortisol is not being converted to what? Inactive cortisol. So you're having aldosterone and cortisol binding on the receptors, they are overwhelming the receptors. So these are some of the issues you have in different organs. You can pause to observe. So causes is mutations in that gene, the HSD11B2 gene, or sometimes you are taking some drugs that are inhibiting that enzyme, 11 beta hydroxysteroid dehydrogenase, like licorice injection, carbendazolone, okay, and also secondary causes like excess cortisol production, like Cushing's syndrome. Clinical features is such a patient will be having high blood pressures. It usually starts in childhood. Okay, low potassium levels because they are losing potassium primarily. Okay, metabolic alkalosis, suppressed plasma renin and aldosterone despite hypertension. They are urinating a lot. Of course, as you are putting out a lot of urine, you want to drink more. So that's polydipsia. And also failure to thrive in children. And also end organ damage. So diagnosis is all those biochemical tests like low renin, low aldosterone, high cortisol to cortisone ratio, genetic testing where there's mutation, confirmed mutation. Probably if you take a history of their drug, they might have ingested this licorice or this carbendazolone drug. So management have to do it. You have to reduce the amount of salt you are taking. And because you have low potassium, you have to supplement potassium. Then pharmacologically, they give you mineralocorticoid receptor antagonists like spironolactone, eplerenone, okay, and also glucocorticoids. And also avoid anything that will trigger it. Okay, avoid anything that will trigger it.